Hello friends, I'm back with more NICU nuggets. I took the last 2 weeks off because I am in the running to be the biggest klutz ever, and I fell on my face and my arm, and between my face looking like I'd been punched and being sore as heck, I figured I would take some time off. And I figured if you can't rest while you're in isolation, when can you? But I'm getting all better now. If I can keep from falling again. And I'm back to talk with everyone again. Yay! Today's topic is a basic one, which is monitors and their numbers and kind of what they all mean. Monitors can rule your life if you let it. And that's not just limited to parents either. We're taught in school to not just look at the monitors and labs, to look at the patient. And that can be really hard to do sometimes. But I'm going to try and help people do just that. First off, I'm going to go over what the monitors look like and just sort of what some of the normal ranges are and why you shouldn't be worried necessarily if you hear the scary noises, usually. So I'm going to show you pictures that I swiped from Google that show some different monitors that I've worked with at different times in my career. There's a lot of different models and brands, but hopefully once you recognize kind of what you're seeing, you should understand what it is I'm saying. And no matter what the brand is, you should be able to recognize which one's heart rate, respers, sats, etc. So I'm going to base this discussion off the monitor that I'm hopefully showing you in a picture right now because it's what we use at my current hospital and I like it and it's what I'm most familiar with, so why not? But again, the biggest thing to remember is that monitors are screening tools only because we can't be there at the bedside 24/7. I mean, we're there, but we can't be staring at each individual baby because we take care of other patients and so like the nurse may have another patient or may need to go to the bathroom on time to time. But they're designed to have, to be a screening tool to help us catch any problems with the baby before it becomes serious. So they're designed to have false positives, which are alarms that aren't real, that seem like the baby is in trouble, but they really aren't. And we do that because it's safer to have a false alarm than it is to have no alarm going off and a baby who needs help. It's really just designed to get people to pay attention to that particular child in the moment, and then they can discern whether it's a real alarm or not. And as an aside, parents should never touch or silence alarms and monitors in the hospital for a couple of reasons. First, liability. I know it seems dumb and when it's a false alarm and you've been there forever, but in the incredibly unlikely event that it's a real issue, we're still legally responsible for the care. And plus we need to know when the babies are setting off alarms to know what's happening, that if, it may be that the heart rate settings need to be adjusted or something else. But most importantly, if you made a wrong call that it was a false alarm and silenced the alarm and the baby actually needed some help, it just delays care to your child. And of course, nobody wants that. So even though it's annoying, please leave the silence button to the professionals. The monitors get their information from 3 little sticky electrodes that are either white, black, and green or white, black, and red. My cat is really enjoying me doing these things. And that the color difference is just a manufacturer variation. I learned to remember how to place them as that white on the right, black against white, and then smoke above fire, because I learned with ones that were red. You could also do smoke above grass. I can't remember if there's something else they say for that. But it's just to knowing how to place them. It's basically on one side of the chest, the other side of the chest, and underneath it. On the monitor cords, then it has a little diagram that tells you which color goes into which hole. And hopefully you'll get to learn that. So when you're giving your baby a bath, you can, a lot of times they need to change the electrodes at that time. So they'll allow you to help change those electrodes. And the other kind of aside thing is when we look at the monitor, it's usually picking between lead 1 or lead 2. And so if lead 1 is getting a lot of artifact or movement from like a burp or the heart rate or something like that, we can switch which lead it's looking for as its primary information giver to try and get better vital signs. And that's, again, another reason why it's good if the nurses know that there's a lot of false alarms, if that's something maybe we can change, because we don't want to have too many false alarms. So usually the heart rate's on the top line, and you're going to see those stereotypical patterns of what a heart rate looks like. And that's called a QRS complex. And you know, it's that straight line and then the spike up and then down and then up again. A normal baby has a pulse between 100 and 200 beats per minute. It is possible to be normal and have a heart rate outside of those parameters, especially when sleeping or angry, because those two can definitely change the heart rate. And your heart rate changes as you get bigger. So a normal heart rate for a 23-weeker might be 170, and a term baby is 120. So I'm not as worried that the 23-weeker has a heart rate of 170, but I might be a little more interested as to why the term baby is sitting at 170. It's something we look at, and it helps us know if there's pain, because that can drive up heart rate. Hydration, because if you're dehydrated, your heart rate goes up. Temperature, your heart rate goes up with your temperature, goes down with your cold. It also can screen for arrhythmias, which are overall really rare in babies. But really what they're looking for is the heart rate slowing down. And babies slow down their heart rate for a variety of reasons. Pain, immaturity, lack of oxygen, overstimulation, boredom. I don't know. There's a lot of reasons. So if we see a lower heart rate, we first want to see if we can see those QRS complexes, so we can tell if it's actually spacing out and getting bigger, or if it is just an artifact and the monitor not picking up the heart rate well. And the sound of the low heart rate alarm is one of the more loud and piercing ones we have, because obviously a heart rate going below our normal standards is something we want to look into. Little digression here. When that alarm goes off, especially, I kind of liken it to meerkats or prairie dogs, because everyone's head kind of pops up and they start looking around to see if they can see whether the alarm is real, which baby it is, if somebody's in the room and fixing the baby already. So if we see somebody's in the room or helping the baby or it's not real, they all kind of return to their work, but it's all and then back to their little cubbies. But it can sometimes be hard for parents because they hear the alarm and it's scary and loud and they want someone to be there immediately, no matter what. But trust me, again, when I say that if there's a real concern, somebody would be there immediately. So don't assume that people don't care or aren't paying attention, even if something seems scary on the monitor, especially if nobody else seems bothered. I mean, it's great to ask your team about those things that you have questions about, but try not to assume that it's for anything bad reasons. Some of it is just that we're used to it and we know really just how worried to be about different situations. Okay, back to the heart rate. So we can pick up some arrhythmias, and one of the more common ones is SVT, which stands for supraventricular tachycardia. And I'm not going to really go into that, but suffice to say, it can mean it makes your heart rate go really fast. And we need to address that. And the other thing that we've more commonly seen is when the heart rate slows down, and that's called brady's or bradycardia, or B's, as in A's and B's. And the A's stands for apnea, which is forgetting to breathe. If you're burping the baby, sometimes it's not unusual to pick up the patting on the back as heart rate too. And you'll see VTAC or VFib and the loud, scary alarms again. Again, just a false alarm. Seizures can also sometimes affect the heart rate. If they stop breathing, it can make the heart rate go down, as happens anytime you stop breathing, your heart rate will go down. Or if they have a breathing tube in so they can't stop breathing, their heart rate will shoot up. So that's just, again, just another one of those little screening things that we use. It doesn't mean if your baby's heart rate goes up that they're having a seizure or something like that. It's one of those things that we're thinking about and what we use that monitor for. I'll say I've had multiple times of monitors reading asystole, which is a flat line or no heart rate, and the baby's crying at the same time. I guarantee you that there is no baby that will be in asystole and be crying. Those just two things don't go together. But that's, again, a throwback to looking at the baby, not just the monitor. So the next thing to talk about is respiratory rate, or respers. And again, it kind of affects us which probe is, or which lead is being looked at, how the baby's lying, and a lot of other factors. And that can make it show higher or lower than reality. Again, it's important to remember screening tools only. Normal respiratory rate for a baby is between 30 to 60 breaths per minute, and it's also BPMs. And breathing fast, which is called tachypnea, actually, so we have all sorts of fancy names, can happen for a variety of reasons, some of which are benign, others not so much. One really common cause of tachypnea in a brand new baby is something that's called transient tachypnea of the newborn, or TTN, which is our abbreviation. It's just a fancy way of saying that the baby's breathing fast and it's temporary, which is what transient means, and it's going to go away. It's a diagnosis of exclusion, though, so it is only used if the baby isn't having any other problems and they're not having any work of breathing. Some people will try and treat that breathing fast, but a lot of times whatever you do, they still breathe fast. Even if you put them on extra respiratory support, it doesn't help very much. It just makes you feel better. So if we think that it's TTN, we're a little more generous in letting them breathe quickly, up to the 90s sometimes if they're comfortable. They're happily tachypnic. The normally we put for the parameters for respers is between 6 and 120 breaths per minute, with an apnea alarm of 20 seconds. Now, the apnea alarm can be really hard to take sometimes, because to be classified as a real apnea, it needs to happen for 20 seconds, or one of the two, that they have to have some sort of change in their vital signs. So their heart rate goes down, their saturations go down, because normally babies can breathe in a pattern that's called periodic breathing, which is just a normal pattern for them, but it's not normal for us. And what they do is they pause, take a big breath, pause, and then do little catch-up breaths. And then take a big breath, pause, little catch-up breaths. That's normal. That is actually completely normal, and they can do that for quite a while. It's only a problem if it lasts longer than 20 seconds, or if there's a change in their saturations or their heart rate. But periodic breathing shouldn't cause, or doesn't cause, desaturations or bradycardia. So if you're having that, that's a sign that it's not from periodic breathing, that it's a real apnea. But don't be scared if you notice your baby pausing and then kind of catching up, and then pausing and then catching up, as long as they are overall doing it, like what they're supposed to be doing. But I also want to reassure you that don't worry, we will remind the baby to breathe. And if they are resistant to our suggestion to breathe, we'll make them. We're mean like that. We like making them breathe all the time, not just some of the time. It's one of my little jokes. I'm the comedian NMP. I will scold the babies about who are apneic, that breathing is not a hobby or a part-time job. It's a full-time career now, so step it up. They very rarely listen to me, but I figure I could tell them. It doesn't hurt, right? On the screen, it will be a line moving in sort of irregular hills that aren't the same rhythm as the heart rate, and it'll look different than the SATs, which is a little smoother. It's kind of hard to describe, but I'm hopefully gonna have a picture for you there. Next thing we're gonna talk about is the oxygen saturation, or SpO2. And this one is actually frequently misheard by families because they hear us say SATs, and it makes more logical sense to someone who doesn't know what it stands for that we're talking about the baby's stats or statistics, or the things that they're doing and their vital signs. But it's actually SATs, which is short for saturations. Like everything else, it's a screening tool only, and it has a lot of limitations. It works by shining a special light that's red through the skin, which either goes on the hand for a baby, or the wrist, or down on the foot. And then it measures how much oxygen is attached to each red blood cell. So in case you don't know, there are a maximum of 4 oxygen that are able to be held on any red blood cell. And we are looking for that as a sort of a proxy or a guesstimate of how much oxygen they have in their system. But this can be misleading sometimes. So imagine you have 100 red cells and they all have 1 oxygen on them. So if you have 100 with 1, that gives you 100 oxygen, and your saturations would read 10% because only 10% of your, or 25%, because only 25% of your oxygen is saturated, or your heme cells are saturated. And if you have 10 red cells and they're all full, that will give you 40 oxygen and SATs of 100%, which the SATs of 100% should mean that you have more oxygen in your body, but the SATs of 25 actually are higher because you have more overall blood circulating. So it can sometimes make it seem like there's enough oxygen in the body, but really the person with the SATs of 25 has more oxygen. So that's a limitation. Another is that it's taken from an extremity, and babies sometimes aren't great about circulating blood to their fingers and toes. I mean, they're new. So sometimes it can show lower than normal because of that. And if a baby's moving around, that can also make it difficult for it to calculate what's the saturation. And one of the biggest limitations that is the least known by parents, doctors, and nurses alike is that saturation monitors are only designed to measure saturations above 70%. So above 70 and above, it's going to be correct within 2 percentage points. That is what they have to meet for quality control and to be approved as a saturation monitor. But below 70%, there actually isn't very much accuracy, and the companies are open that they don't claim that there's any accuracy. So it becomes even more important that if the saturations are below 70, is to look at the baby and not on the monitor. The SATs might say 2, but if the baby's pale but still pink with a normal heart rate, they definitely do not have a SAT of 2. they would be deep purple or blue or straight up white if their SATs were truly that low. So when you see SATs that are scary in the 30s, don't necessarily panic. It's possible or likely that the baby needs help and they're desaturated, but it's maybe not quite as bad as it looks on the monitor. That's just a hard one to remember because it's hard to see that number of SATs of 40 or 50 and not feel panicked a little bit. The goal for premature babies is we would like their SATs to stay between 88 and 92%, and we figured that out sort of through trial and error. Too much oxygen for premature babies hurts their eyes. Too little oxygen hurts their brains, and so that's kind of our happy medium. But really, that's really a goal for us giving oxygen, because if the baby's saturations are 100% and we're not giving them any oxygen, we're not going to hold our hands over their mouth or something like that to make them stop breathing. We just will turn down oxygen that we're giving if their saturations are high. So if they're sitting at 93% and we are giving them 30% oxygen, it might be a sign. Scooch that oxygen down a little bit. Normal oxygen in the atmosphere is 21%, by the way, in case you didn't know. For term kiddos, ideally, they should be over 94% pretty much all the time, as long as they have healthy lungs, of course. Babies with heart defects, they can also have sort of a special situation. Depending on the defect. If they have what's called a ductal dependent lesion, or one that relies on that PDA that I kind of referenced earlier, your saturations can be higher before and after that. But in general, our goal is to have saturations between 75 and 85 for a baby whose blood mixes in an unusual way. The biggest takeaway, again, is that, like all things on the monitor, take it with a grain of salt, listen to your providers, and if you have questions specifically about things that happen to your baby or different goals for your child, ask your providers. They're probably happy to answer, and there's likely some good thinking that has gone into why they are doing it that way. So blood pressure, next up. Blood pressure is usually a small number towards the bottom of the screen. Unlike big people, one of the biggest, our main concern on that blood pressure is the mean arterial pressure, or MAP. Normally you get a blood pressure that is systolic, diastolic, and then a little number in parentheses, which is your MAP, which is a calculated number. That mean arterial pressure, MAP, tells us kind of some of the baseline pressure that's in the body. And it's important, especially for babies, because they're not very good at maintaining blood flow to their brain in an active way. They have a lot of passive mechanisms that you or I, if our blood pressure drops down suddenly, we still do a pretty good job keeping blood to our brain. If babies' blood pressure drops down suddenly, they don't do quite as good of a job. So that's why we look at the MAP so closely. But cuff pressures are another incredibly inaccurate measurement that are affected by movement, placement of the cuff, position of the baby, size of the cuff, the baby's mood, and lots of other things. The goal is to have a MAP that is greater than or equal to the baby's gestational age. So a 23-weeker should have a MAP of at least 23, and a 32-weeker should have a MAP of at least 32. We do look at the systolic and diastolic for some other things, but the MAP is what we really focus on, and it's crucial for babies, which is just funny because adults, they never talk about the MAP. It's just not something they worry about. Invasive blood pressure. So the cuff blood pressure is usually a little box, and if there's invasive blood pressure, it's usually a line, just like the SATs or the heart rate or the respirators. And that is very accurate blood pressure reading. That it comes either from a peripheral arterial line or a PAL, which is in either the hand or the wrist or the ankle, or the umbilical arterial catheter, And either way, those are very accurate overall. I'll always believe invasive blood pressure over cuff blood pressures. A physician I used to work with in the past used to call cuff blood pressure random number generators, just because it can be so off. But whether we're looking at invasive or non-invasive, we also look for other signs to correlate that blood pressure, to make sure that there is adequate amounts that are getting to the different parts of the body before deciding to treat low blood pressure. We'd look at things like how much pee do they have, because if the babies are having trouble keeping their blood pressure up, they won't give as much blood to their kidneys, which will make the amount of urine they go down. Or, you press on the skin a little bit and then see how long it takes for the skin to go from being blanched or white back to its normal color. Normally it just takes less than 3 seconds, 2 to 3 seconds or less. And if they're having trouble pumping all of their blood or having enough pressure to get it to all the parts of their body, that will take longer. Sometimes you'll see a second line of saturations, and that's if there's a concern for shunting, which is basically blood skipping the heart skipping the lungs for some reason. Or it could skip the body, depending on which direction it's going. But it can, it just basically means that when you're shunting, that your blood isn't flowing in the perfect, correct pattern. And because of this, your saturations are going to be different between the right hand and the rest of the body, really. So like I said, I don't know if I said this before, but your aorta has this arch, and then you've got your PDA, which connects to things, and your right hand and your brain all happen before the PDA, and everything else comes after the PDA. So the right hand and the head get blood right after it leaves the left ventricle. But if there's a problem with the flow, it's often after that part of the trip. So we measure the saturations before and after. And so you'll see something marked pre and post, preductal and postductal. So we are just looking, it just sometimes is, if they have a big differential, sometimes we will target different numbers or be more concerned if one of the numbers go down than the other, or if there's a difference between the two numbers and the difference gets bigger. So if they have that shunt and there's concerns, we'll watch both numbers. Some hospitals will have a temperature probe too, and you'll see a temperature on there. And it's actually connected to the monitor. So the baby, if they're in a warmer bed or an isolette, which is the box, or the warmer bed has the heating element up top, those have temperature probes that go on the baby that help measure the baby and keep the baby the right temperature. And then we also check a different way outside of the bed as well. And some places do it continuously, and other places will check it every 3 to 4 hours when the nurse comes in to do her care, which is what we call coming in to change a diaper and feed the baby and all of those things. And so the normal range for temperatures is between 36.2 and 37.6 degrees Celsius. We usually use Celsius in the NICU. 38 degrees is considered a fever. It's 100.4 in Fahrenheit. Like everything, probes can become dislodged, a baby can be warm from crying or snuggling or a medication or something other reason. So it's a screening only tool. Fun fact, babies are not very good at having fevers. So if you have 2 term babies and one baby is 37.7 degrees and the other baby is 36 degrees, with both being equal in the appropriate dress and appropriate environment, etc., I'm more concerned about the baby that's 36 degrees instead of the baby who is a little bit on the warmer side. Usually when babies get sick, their temperatures drop. They have to work so hard to maintain their own temperature and heat that when they have an extra stress on their system, they just don't have energy to heat themselves. There's always exceptions, and there are some infections that are more likely to provoke fevers than others, but especially with preemies and brand new newborns, they rarely ever get true fevers. Another thing sometimes you can see is measuring the pressure in the umbilical venous catheter, if you have one. That's, again, just a screening done for looking if it's malpositioned, if it's gotten pulled back or pushed in a little bit. The numbers are different based on whether it's in the liver or in the chest cavity. And you want it in the liver and not, you want it in the chest cavity and not the liver. Very important. And so they look to see how that waveform moves. It should go down when the baby takes a breath in, and it's just one of those screening tools. So that should get you started on all of those numbers on the monitor. We've got heart rate, respers, SATs, temp, and our invasive measurements, and I think that's everything. If you have any questions, leave me a comment. If you have an idea for something you'd like me to talk about, leave a comment. Hopefully in the next week or two, I'm gonna have one of my colleagues who has decided that she would love to be a guest on my show. And we'll be talking about different issues. She's got a list. We got some great ideas. And I hope you are all staying safe in this time of COVID, and be good to everybody, and it's great to see you. Bye.